Bismillah ar-Rahman ar-Rahim. My name is Dr. Islam Shawky Abdulaziz, Professor of Cardiology at Al-Azhar University. Our talk today is basic testing and advanced diagnostics in chronic coronary syndrome, selecting the appropriate test. Most of the data included in this talk is behind the recently published paper from the European Society of Cardiology 2019 Guidelines for the Diagnosis and the Management of Chronic Coronary Syndrome. We know that coronary artery disease is a pathological process characterized by atherosclerotic plaque accumulation in the epicardial arteries, whether obstructive, causing acute coronary syndrome, STEMI, or non-STEMI myocardial infarction, or non-obstructive, causing ischemic heart disease. Coronary artery disease can be modified by lifestyle adjustment, pharmacological therapies, and invasive interventions causing stabilization or even regression of the disease. Coronary artery disease may become unstable at any time, typically due to an acute atherothrombotic event caused by plaque rupture or erosion. And this is the clinical scenarios in patients who suspected or established chronic coronary syndrome. Patients with suspected coronary artery disease and stable symptoms, patients with new onset heart failure or LV dysfunction and suspected coronary artery disease, asymptomatic or symptomatic patients with stabilized symptoms less than 1 year after acute coronary syndrome, or patients with recent revascularization, patients more than 1 year after initial diagnosis or revascularization, patients with angina and suspected vasospastic or microvascular disease, and finally, asymptomatic subjects in whom coronary artery disease is detected at screening. There are a couple of basic testing should be done mandatory for all patients with suspected coronary artery disease. This includes standard biochemical testing, resting ECG, resting echocardiography. And there is some tests can be used on demand on the same patients, like ambulatory ECG monitoring and the chest X-ray. As regards basic biochemistry for initial diagnostic management in patients with suspected coronary artery disease, the guidelines mentioned that if evaluation suggests clinical instability or acute coronary syndrome, repeated measurements of troponin, it's better to use high sensitivity or ultra-sensitive assays are recommended to rule out the presence of acute coronary syndrome. This is class 1 level of evidence A. Again, there is another couple of biochemical tests used for initial evaluation of patients with suspected coronary artery disease. The following blood tests are recommended in all patients: full blood count, including hemoglobin, creatinine and renal function assessments, lipid profile, and screening for type 2 diabetes, as we know that diabetes is associated with 2 to 8-fold increase in myocardial mortality in patients with coronary artery disease, and also assessment of thyroid function is recommended in case of clinical suspicion of thyroid disorders. How about the initial diagnostic management of patients with suspected coronary artery disease? Resting ECG is a routine for all patients with suspected coronary artery disease. Resting 12 leads ECG is recommended in all patients with chest pain without an obvious non-cardiac cause. This is class 1 level of evidence C. 12 leads ECG is recommended in all patients during or immediately after an episode of angina suspected to be indicative of clinical instability and the development of acute coronary syndrome. This is class 1 level of evidence C. Ambulatory ECG, as we mentioned, may be needed in some patients with suspected arrhythmia. This is class 1 level of evidence C. And in some patients with symptoms or signs of vasospastic angina, and this is class 2 level of 2A level of evidence C. Resting echocardiography is crucial in the screening and the diagnosis of patients with suspected coronary artery disease. It's recommended in all patients for exclusion of alternative causes of angina, like valvular heart disease or LVH, etc. Identification of regional wall motion abnormalities, measurements of left ventricular ejection fraction, which is very important for risk stratification and the prognosis of patients with coronary artery disease, and finally for evaluation of diastolic functions. In some patients, because of special characteristics like poor acoustic window, we may need CMR, cardiac MRI, may be considered in those patients with an inconclusive echocardiographic test. And the class of evidence for CMR in those patients is 2B and the level of evidence C. Chest X-ray, as we mentioned, may be needed in some selected patients with symptoms and signs of heart failure or patients with suspicion of pulmonary disease. The class is 1, level of evidence C. After doing the initial evaluation with the appropriate biochemical testing, ECG, echo, chest X-ray, etc., in patients in whom revascularization is unexpected or useless due to comorbidities and the overall quality of life, the diagnosis of coronary artery disease can be made clinically and the only medical therapy is required. If the diagnosis of coronary artery disease is still uncertain, establishing a diagnosis using non-invasive functional imaging for myocardial ischemia before treatment is reasonable. This chart shows the pretest probabilities of obstructive coronary artery disease published in the guidelines of the European Society of Cardiology 2019 in evaluation of patients with chronic coronary syndrome. The data behind around 16,000 symptomatic patients according to their age, sex, and the nature of symptoms. The data showed clearly that patients with typical symptoms and increased age having very high pretest probability, and patients with atypical symptoms and non-anginal or atypical symptoms, young age, they having low pretest probabilities for coronary artery disease. And as we can see, the regions shaded dark green with a pretest probability more than 15%, those patients benefited from non-invasive assessment, from non-invasive testing. And the regions shaded light green with pretest probability 5 to 15, testing for diagnosis may be considered after assessing the overall clinical likelihood based on the pretest probabilities and patient initial evaluation. Like those patients with normal exercise ECG or 0 calcium score at multi-slice CT, those patients having a very low likelihood for coronary artery disease. While patients with increased likelihood, if they had pretest probability between 5 and 15 with multiple risk factors like dyslipidemia, diabetes, hypertension, smoking, or family history, patients with resting ECG, patient changes, patients with LV dysfunction, suggestive of coronary artery disease, patients with abnormal exercise ECG results, or patients having calcium score on multi-slice CT. Those patients may need further non-invasive functional assessment indeed. And this figure showed clearly that patients with low to moderate risk for having coronary artery disease, they may benefited more from cardiac CT. While patients with moderate or moderate to high pretest probability for coronary artery disease, may benefit more from functional non-invasive assessment, as we can see in the chart. While patients with very low risk, with very low test probability, they may need nothing, just reassurance, and the patients with very high pre-test probability, they may be benefited more from invasive strategy, invasive coronary angiography right away. And this is the diagnostic pathway which fits each non-invasive test in its place. In all non-invasive test assessment, local expertise and availability is mandatory. As regards the coronary CT, it's suited better for patients with low clinical likelihood. Patient characteristics suggests high image quality like slim patients, patients in sinus rhythm, patients with slow heart rate, and also it's better for patients when we need some information about subclinical disease, like patients with multiple risk factors and strong family history, even if they are asymptomatic. Those patients, they may have subclinical atherosclerosis, and the best to tell is the coronary CT. And according to the results of cardiac CT, if the patient had mild disease, those patients may be on medical therapy, no need for further investigations or for invasive coronary test. If the results is inconclusive, we may need further assessment by non-invasive functional assessment, and if the results is associated with high-risk patients, like patients with significant stenosis in the proximal 3 vessels or proximal LAD or left main disease, those patients should be referred for invasive coronary angiography. How about non-invasive functional imaging? Again, local expertise and availability is a must. But this test is suited better for patients with high clinical likelihood, for patients in whom revascularization is most likely, and also when the question of viability assessment is required. Again, there is some patients at very high risk, very high likelihood for coronary artery disease. They're having typical symptoms. They're having resting ECG changes. They're having LV dysfunction and the drop of ejection fraction suggestive of coronary artery disease. Those patients may not need either anatomical, non-invasive anatomical assessment or functional assessment. Those patients may go right away for invasive coronary angiography. And this is the diagnostic pathway recommendation published in 2019 European Society guidelines. It mentioned that non-invasive functional imaging for myocardial ischemia or coronary CT is recommended as the initial test to diagnose coronary artery disease in symptomatic patients in whom obstructive coronary artery disease cannot be excluded by clinical assessment alone. This is class 1 level of evidence B. It's recommended that selection of the initial non-invasive diagnostic test is done based on the clinical likelihood of the coronary artery disease and other patient characteristics that influence test performance, local expertise, and the availability of the test. This is class 1 level of evidence C. Functional imaging for myocardial ischemia is recommended if coronary CT has shown coronary artery disease of uncertain functional significance, like moderate lesion in proximal LAD or proximal RCA, or if it is not diagnostic, like patients with high calcium score or patients with motion artifact, etc. Invasive coronary angiography is recommended as an alternative test to diagnose coronary artery disease in patients with high clinical likelihood, severe symptoms, refractory to medical treatment, or typical angina. This is class 1 level of evidence B. Invasive coronary angiography with the availability of invasive functional evaluation by using FFR, invasive FFR, should be considered for confirmation of the diagnosis of coronary artery disease in patients with an uncertain diagnosis on non-invasive testing. Cardiac CT should be considered as an alternative to invasive coronary angiography if another non-invasive test is equivocal or non-diagnostic. This is class 2A level of evidence C. How about exercise ECG? For the use of exercise ECG in the diagnostic pathway, it's recommended for the assessment of exercise tolerance, symptoms, arrhythmias, blood pressure response, and the event risk in selected patients. This is class 1 level of evidence C. In this figure, we can see the performance of different diagnostic tests for the detection of anatomically or functionally significant coronary artery disease. And as we can see, that exercise ECG have the lowest sensitivity and specificity. And of course, positron emission tomography, PET imaging, and the stress CMR having the best sensitivity and specificity. However, they are technically demanding and time-consuming. Stress echo and the SPECT CT having modest sensitivity and specificity. They are widely used and easily interpreted. While coronary CT having the best sensitivity and of course the best non-invasive test with an excellent negative predictive value to rule in patients for coronary artery disease, especially young patients. In the coming 3 or 4 slides, we will see the mechanisms of interpretation, the strengths, the limitations, consideration, and recommendation of different non-invasive tests used for evaluation of patients with suspected coronary artery disease or patients with chronic coronary syndrome. And as we mentioned, stress ECG has the lowest sensitivity and specificity. It's a 12 leads ECG monitoring during exercise. It's considered positive when we have more than 1 millimeter ST segment depression or elevation in 2 contiguous leads, or significant arrhythmias at low exercise tolerance, or hemodynamic instability like drop of the blood pressure. Of course, the high-risk exercise test, if we have less than -10 or -11 Duke treadmill score. It's non-invasive, it's very low cost, it's quick, and it's assess the functional capacity, it's widely available, and it can be done on outpatient clinic or even at office. However, as we mentioned, its sensitivity and specificity is low, and it's variable according to the different patient characteristics. It's of no value almost if we do it for patients with left bundle branch block, for patients with pre-excitation, for patients with resting STT wave changes. The results is non-diagnostic. So it's better to do functional imaging. So exercise ECG is no longer solely recommended for evaluation of de novo coronary artery disease patients. It can be used for risk stratification before discharge and before planning for functional imaging later on. Stress echo having a better sensitivity and specificity when it's compared to exercise ECG. Its sensitivity and specificity is comparable to stress myocardial perfusion imaging SPECT study. Its mechanism of interpretation that it can be done with exercise or pharmacological stress. We can assess ventricular size, wall motion abnormalities in the same test. It's abnormal when we have new wall motion abnormalities or abnormal left ventricular ejection fraction drop with stress. Of course, stress echo is non-invasive. There is no radiation. It adds simultaneous structural information and the localization of the ischemia with improved sensitivity and specificity when it's compared to exercise ECG. However, its performance is reduced in patients with limited window, with poor acoustic window. It's to great extent operator dependent and largely qualitative analysis. So we need to consider further assessment if we have patients with poor acoustic window or obese patients or patients with chronic obstructive pulmonary disease. SPECT imaging having comparable sensitivity and specificity to stress echo. It serves millions of patients since 1973. It depends on the injection of radioactive materials. Recently, we using only technetium-based isotopes, cysteamine or tetrofosmin, both during rest and stress. And we're looking for heterogeneity of the flow between normal and abnormal vessels. It's easy to interpret if you conduct a good study. Abnormal study defined as perfusion defect or wall motion abnormalities on gated SPECT. Of course, there is radiations, around 12 millisievert radiation exposure if we do complete study. In some selected patients, we may only do stress part of the study, and radiation exposure is around 3 millisievert. It's ideal for patients with poor echo window or patients unable to exercise if we combine SPECT imaging with pharmacological stress. We will talk a little bit about SPECT imaging. As we can see from this study published 20 years back by Dr. Rory Hakumovich, it showed clearly that the event rate myocardial infarction or cardiac death is higher when the perfusion defect increases. We can see patients with normal study, they having event rates, either myocardial infarction or cardiac death, less than 1%. And this event rate increases more than 10 times if we have large or severe abnormality on the myocardial perfusion imaging. In more than 10,000 patients, Hakumovich proved that patients with low or minimal ischemia, small amount of ischemia, those patients benefited more from medical treatment. And those patients having cardiac death rate and event rate extremely high if they underwent revascularization. And on the other hand, patients with large perfusion defects benefited more, they having low cardiac death, low events if they underwent revascularization. And if we kept those patients on medical treatment, the event rate in the form of cardiac death is significantly higher. This is an example of patients with normal myocardial perfusion imaging. If this patient exercised well and achieved good target heart rate, the event rate, annual event rate in this patient is less than 1%. On the other hand, this patient with multivessel disease, he had larger reversible perfusion defect at the apex, anteroapical, septum, lateral wall, infero-posterior segments. This patient is benefited from revascularization, and the event rate is high in this patient if he went on medical treatment. Calcium score is there as anatomical assessment for patients with suspected coronary artery disease or chronic coronary syndrome. It had low sensitivity and specificity for detection of stenotic lesion, and the score is calculated based on the volume and density of the calcification, and it's called Agatston score. The best result is to have 0 calcium score in asymptomatic patients, while in symptomatic patients, 0 calcium score may mean nothing because those patients may have non-calcified occlusive lesions. So 0 calcium score in asymptomatic patients is associated with excellent results and excellent prognosis. It's very modest radiation dose, it's very easy and extremely reproducible test. So it's recommended for patients with multiple risk factors with suspected coronary artery disease and asymptomatic patients. And this is the calcium scale, is a linear scale with 4 calcium score categories. 0 is none, from 1 to 99 is mild, above 100 to 400 is moderate calcification, and the more than 400 is severe calcification. Calcium score correlates directly with the risk of events and the likelihood of obstructive coronary artery disease. And this is the results of the MESA trial published in New England Journal of Medicine in 2008. It showed clearly that the higher the calcium, the higher the cumulative incidence of coronary events, with a statistically significant difference between different categories. Calcium score, even if we apply it to the same risk category, like patients with intermediate risk for coronary artery disease, it's still able to re-stratify those patients into high risk patients with high calcium and low risk patients with low calcium. It works in all patients, both in men and women. Cardiac CT, having the best sensitivity as non-invasive test to rule in or rule out coronary artery disease. Its negative predictive value approaches 100%, 99% negative predictive value. It's non-invasive. It detects obstructive coronary artery disease. It's quick. And also, recently, we can assess functional flow reserve by cardiac CT. However, it doesn't confirm ischemia, especially in patients with borderline or moderate lesions. There is some pitfalls in the study, like patients with high calcium or motion artifacts. And again, it's contraindicated in patients with renal impairment or patients with radiation, with contrast sensitivity. And it's very powerful test in rule out with an excellent, very high negative predictive value. And the great promise of applying multi-slice CT for patients with chest pain and chronic coronary syndrome is the triple rule out. It can exclude patients with dissection of the aorta, patients with significant coronary lesions, patients with pulmonary embolism. This is an example for patients with normal study. As we can see, LAD, LCX, and RCA, smooth vessels. And in this patient, if he had chest pain, we can send him home surely with a very excellent negative predictive value, 99%. This is another patient with chest pain and normal ECG, and he had unequivocally normal coronaries, as we can see. While this patient had proximal LAD high-grade stenosis, we can see non-calcified, mainly non-calcified, there is a small calcific, and the mainly non-calcified plaque, causing high-grade, more than 90% stenosis in the proximal LAD, and this patient indeed needs invasive intervention. So another patient with ostial proximal LAD, multiple mixed plaque, causing near total occlusion, and the right coronary is ectatic and atherosclerotic with significant lesion in the BDA, and again, this patient must underwent revascularization. Another young patient with non-calcified plaque causing high-grade stenosis, almost total occlusion in the proximal LAD. In this chart, we can see the definition of high event risk for different test modalities in patients with established chronic coronary syndrome. For exercise ECG, the cardiovascular mortality is more than 3% per year according to the Duke treadmill score. If the Duke treadmill score is less than -10 or -11, the cardiovascular mortality is more than 3%. In myocardial perfusion imaging or PET perfusion imaging, if we have moderate to large or large amount of ischemia, more than 10%, this is high risk scan, and this patient should undergo revascularization. For stress echocardiography, more than or equal to 3 out of 16 segments with stress-induced hypokinesia or akinesia, this is high risk patient. For cardiac MRI, more than or equal to 2 segments out of 16 with stress perfusion or more than or equal to 3 segments with dobutamine-induced dysfunction, this is high-risk images. For coronary CT or invasive cardiac CT or invasive coronary angiography, if we have proximal lesion in the 3 vessels or proximal lesion, significant lesion in the left anterior descending or left main disease, this is high-risk patient. And this is the points we need to consider in choosing the investigative modality for evaluation of patients with suspected coronary artery disease. System consideration, the local experience, availability, accessibility, cost, and reimbursement of the technique. Test consideration, sensitivity, specificity, and the prognostic value of the test. And patient factors which may decide which test we are going to use: the body habitus, exercise capacity, renal dysfunction, contrast tolerance, claustrophobia, and the baseline ECG. And this is the new major recommendations in 2019 European Society of Cardiology guidelines regarding the basic testing, diagnostics, and risk assessment. Non-invasive functional imaging for myocardial ischemia or coronary CT is recommended as the initial test for diagnosing coronary artery disease in symptomatic patients in whom obstructive coronary artery disease cannot be excluded by clinical assessment alone. This is class 1. It's recommended that selection of initial non-invasive diagnostic test be based on the clinical likelihood of the coronary artery disease and other patient characteristics that influence test performance, local expertise, and the availability of the test. Again, it's class 1. Functional imaging for myocardial ischemia is recommended if coronary CT has shown coronary artery disease of uncertain functional significance like moderate lesions, or if it's not diagnostic like patients with high calcium score. Invasive coronary angiography is still option and recommended as an alternative test to diagnose coronary artery disease in very high-risk patients. Invasive functional assessment must be available and used to evaluate stenosis before revascularization unless the patient had very high-grade stenosis, more than 90% luminal stenosis. It's again class 1. Coronary CT should be considered as an alternative to invasive angiography if another non-invasive test like stress perfusion study or stress echo is equivocal or non-diagnostic, and this is class 2A. My conclusion is the key messages published in 2019 guidelines. Careful evaluation of patient history, proper physical examination, and the basic testing are crucial for the diagnosis and management of patients with chronic coronary syndrome. Unless obstructive coronary artery disease can be excluded based on clinical evaluation alone, either non-invasive functional or anatomical imaging may be used as the initial test to rule out or to establish the diagnosis of chronic coronary syndrome. Selection of the initial non-invasive test is based on the pre-test probabilities, the test's performance, patient characteristics, local expertise, and the availability of the test. For revascularization decision, both anatomy and functional evaluation are to be considered. Assessment of risk serves to identify chronic coronary syndrome patients at high risk who are projected to derive prognostic benefits from revascularization. Thank you very much for your attention.